Hi, everyone. I'm Dr. Tina Ziania, and it's my honor and pleasure today to welcome Dr. Connie Lehman, Professor of Radiology at Harvard Medical School and one of the world's foremost leaders in breast imaging. Dr. Lehman has published more than 200 scientific papers, co-authored national guidelines for breast cancer screening, and led landmark clinical trials that have shaped how we detect breast cancer. Most recently, she and her team developed the first FDA-authorized AI platform for breast cancer risk prediction, which transforms mammography from a tool of detection to one of prediction and prevention. Her pioneering work is not only advancing science, but also changing patient care and improving outcomes for women everywhere. Please join me in welcoming Dr. Lehman. You can take the floor.
Thank you so much, and hello everyone from wherever you're joining us. I'm going to share some of my journey in the domain of really unlocking the power of radiology and of images of the human body with artificial intelligence. And this really is a new frontier. I feel so fortunate to be born in this time where we're experiencing this revolution of AI, and in particular, how we're applying it to improve the outcomes for our patients. So, as a radiologist and as a breast imager, I've always been focused on early detection. And early detection means everything. When we detect breast cancer and diagnose it when a woman is at stage 0 to 1, meaning DCIS in the earliest stage of invasive breast cancer, we cure. So we often have that expression that, the bad news is that we did find cancer in your biopsy, but the good news is this can be cured. We can't say that about uncontrolled hypertension or a lot of diseases that are chronic and just have no cure. But we can say that when we detect breast cancer early. But if we don't detect it early, and if it's diagnosed when it's metastasized or stage 4, the survival really plummets. And if we think of this through the longevity lens, we want all our patients to live longer and with higher quality of life after treatment. Not only is the mortality outcomes different, but also the morbidity associated with the treatment. So a woman diagnosed with early stage breast cancer has such less invasive and such less morbid treatment, and that she carries with her through the rest of her life. So the impact on her overall health can be dramatically reduced when she has less aggressive treatment associated with earlier cancer detection. And it's concerning because breast cancer incidence continues to increase. And this is especially true in women who are Black and also women who are young. So we are really trying to get ahead of this because we've also found that while we were making great inroads on decreasing breast cancer mortality, that has sort of flattened off. So the survival has flattened, but the incidence is increasing. And we have to ask ourselves, why is that? I think as a radiologist, I noticed that we continued to focus on new and more advanced and more exciting technology, going from film screen mammography to digital mammography to 3D tomosynthesis mammography, contrast enhanced mammography, contrast enhanced MRI, ultrasound. So new technology, but we were pairing that with really outdated delivery models. So this poster is from the American Cancer Society in the 1970s. If you haven't had a mammogram, you need more than your breasts examined. And this then the tagline says, if you're a woman over 35. So it was really, we've been stuck with age-based screening for large populations of women when we have so much more information about women where we could shift, and rather than doing really outdated age-based screening with mammography alone, we could have risk-based screening where we get the right test to the right woman at the right time. So it's not that people haven't been trying to use risk to open more doors for women to have their cancers identified earlier. So if a patient is assessed at being increased risk, our guidelines now suggest that she needs more than just a mammogram. She might be recommended to have breast ultrasound or breast MRI, and not only be guided down different pathways for early detection, but also to consider better methods for prevention. Now, we want everyone to follow lifestyle changes to decrease your risk of breast cancer, metabolic disorders, to encourage and increase your brain health and your heart health. But it's particularly in women who have high risk of breast cancer that we really can have different pathways for preventing the cancer from occurring. But the problem is that while risk assessment is a critical metric in access to life-saving care, our traditional risk models fail to reach most women who will be diagnosed with breast cancer. And that's sort of surprising to think about. But on the other hand, it's one of the most common stories that I have in the clinic. When a woman who's told that she's been diagnosed with breast cancer, her mammogram was performed, her biopsy results came back, and it showed evidence of cancer, the most common response is, how can that be? No one in my family has had breast cancer. How is that possible? So we have story after story, whether it's Katie Couric or our younger patients, just being shocked by their breast cancer diagnosis. And we think it's time to change that rather than say, I know, most women don't have a family history. In fact, 85% of women diagnosed with breast cancer have no family history of breast cancer. More than 90% have no known genetic mutation with the family. Of the 2.3 million women worldwide diagnosed with breast cancer year after year after year, the vast majority of them are surprised because we have not identified them in advance as being at increased risk for breast cancer. So we also have challenges with traditional risk models because they are what we refer to as they favor white women engagement. At Mass General, we did a large study looking at the Tyrer-Cuzick version 8 traditional risk model, which is one of the more common risk models. And we found that half of our women who identified as white were assessed at increased risk. A third of our patients who identified as Asian or Black were identified by our traditional risk models at increased risk, and only 20% of our patients who identified as Hispanic. And those percentages do not track with the cancer incidence. One of my colleagues, David Jones, wrote a beautiful article in the New England Journal called Hidden in Plain Sight, Reconsidering the Use of Race Correction in Clinical Algorithms, saying that though these models are intended to help conceptualize risk and guide screening decisions, they may inappropriately discourage more aggressive screening among some groups of non-white women. So we have a lot of work to do in these traditional models, and there are many failures. Now, some people are saying, well, it should be all about breast density. Let's make sure that all women know if they have dense breast tissue, and let's inform them that this increases their risk. I'll show some data later when we compare our AI risk models to density, but I'll just cut to the chase and share with you now that while it's federal law that all women in the US, by law, we need to inform them of their breast density, and we need to let them know that because of their dense breast tissue, they could have their cancer missed on the mammogram and they're at increased risk of breast cancer. Now, this communication is very well intended, but unfortunately, half of all women who undergo screening mammography are told they have dense breast tissue. And to have all of these women undergo MRI and supplemental testing is really going to throw the balance off of potential benefits and harms. We're going to be doing a lot of unnecessary testing, unnecessary biopsies, and women that, although they have dense breast tissue, actually aren't at increased risk for breast cancer. And we're going to leave a lot of women behind because there are women who don't have dense breast tissue that are at significantly increased risk of a future breast cancer and need just as much attention as the other cohort with dense breast tissue. So for some time in radiology, we have seen that the mammogram itself holds untapped risk information. In the 1970s, John Wolfe noticed that his patients that developed breast cancer had mammograms that just looked different than his patients' mammograms who never went on to develop breast cancer. So just the standard screening mammogram that most of us are getting every year or two contains thousands of subtle patterns that are invisible to the human eye. I can study them a long time, and I've been a breast imaging specialist for a long time, but I can't predict a woman's individual risk from that mammogram. But deep learning models can. They can extract these patterns directly from the image. There's no extra testing needed, no additional radiation, no questionnaires required. We use the simple screening mammogram that's been obtained for cancer detection and diagnosis, And now we leverage that predictive data into giving the woman a much more accurate risk score. And it's been really exciting to be able to leverage computer vision and the power of AI to extract more information than just breast density or is there a current cancer on the mammogram. And we did this because of all the shoulders we stand on of these brilliant computer scientists that had developed deep neural network processes where you could take images, label them, and allow the computer to learn on its own how to recognize, in this example, if an image is of a cat or a dog. We used exactly those types of software programs and deep learning algorithms, and we provided the computer with hundreds of thousands of mammograms, but we labeled the mammograms as being appropriately, accurately, either a woman who developed breast cancer in 5 years or in a woman who did not develop breast cancer. And the computer learned. It learned subtle patterns that I cannot guide it to follow that predicted a woman's future risk of breast cancer. Now, this took a lot of work. The first foray into this was with my colleague at MIT, Regina Barzilay, in her lab. I had developed a very large database at Mass General, and we used this breast imaging data repository archive resource, again, to over 260,000 exams in almost 80,000 patients. And we trained, validated, and tested the model, and we were able to then evaluate in many diverse patient populations how our AI image-based breast cancer risk model performed. Of all the studies we did, I was probably most excited when I realized that we could have a model that brought equity back into the picture of risk assessment. So we compared the most commonly used traditional risk model, the Tyrer-Cuzick version 8, shown by the blue bars, in white, in Asian, and in women who identified as being African American or Black, and found the inequities that we had seen reported in the literature before. But what was really exciting to see that not only did our AI model outperform the traditional risk models, but also supported a level of equity that we had just failed to deliver with our traditional risk models. So then, as we were doing that study and we had that research model, Peter Slavin, who was at the time president of Mass General, said, "I'd really like to see you take this science and provide access globally to more women. And you're going to need to do that through a commercial pathway." I was admittedly very hesitant about that. I had been in academic medicine my entire life, but he was very persuasive and really was so persuasive in underscoring the importance of different pathways to have an impact. And saying, if you really want to have this impact, you're going to need to have it move outside of the academic centers and around the globe. So I founded a company with a very strong support and backing of Sante Health, which is a VC group, which has been amazing partners on this journey. And we collected data and mammograms with known clinical outcomes from around the world, over 2 million screening mammograms. The company is Clarity Breast. We did a lot of work to develop this new model and to try to move it into the clinic. Just a few months ago, we received our FDA de novo authorization. It is an image-only AI model to predict breast cancer risk from a screening mammogram. For the FDA, we validated across 77,000 mammograms from 5 US health systems. I thought that was really important because it wasn't that long ago that 98% of all AI models were developed on patients that live in 3 states, California, New York, and Massachusetts. And we really wanted to make sure that our input was diverse and our validation was representative of a diversity of patients across geographic locations, races, ethnicity, age, breast density, et cetera. Now, with the FDA authorization, we're actively integrating into leading health systems. And our projected rollout, this is all happening very fast, is tens of thousands of women expected to receive an AI-derived risk score within the next year. So this has really been our vision from the very beginning, and we're actually starting to realize that, which is really exciting, that we can have risk-adapted screening that's more equitable, more efficient, and also we can move into prevention. So the FDA first was needed before we could start to integrate into any health systems, and that was a big lift and a very exciting time. But I think it's not just about the FDA clearance for this particular product we have, the Clarity Breast Risk Score. I think it's because it's the first time the FDA cleared a predictive test in otherwise healthy patients from an image alone. So we have a lot of tests that can take a patient with a known cancer and then image that cancer and help guide and direct the treatment or direct how likely this patient is to respond to treatment. We can do the same thing with cardiovascular disease. So we can image a patient with known disease and make predictions about that. But to take an image and then predict future health in an otherwise healthy patient is a new domain. This is also something where the radiologist does not overread this. I can certainly and do need to overread a CAD detection or a CAD diagnosis software mark on a screening mammogram because that's to help me read the mammogram better for detection and diagnosis of breast cancer. But I can't do that for risk assessment. So this is really outside of what the radiologist does. This is leveraging AI to do something a human actually can't do, not try to help the human do it a little bit better. So I predict there's going to be a lot more risk models that are going to come through this pathway. Now that the de novo pathway is established, I think we'll see many, many more. And it's been exciting to engage with people in the domains for, regulatory processes, for guidelines with the American Cancer Society and the NCCN, and for other thought leaders in the field that are looking for ways that we can use radiomics and imaging data to really help assess risk, predict the future, and then intervene to reduce that risk. So the performance is very consistent and very strong. When we look at our Clarity risk score compared to traditional risk scores, it really translates so that we can find twice as many women who will develop cancer at the next screen being placed in those high risk groups so that we know in advance of that rather than the methods we were using with traditional risk scores, and the equity and the strong calibration so that the percent risk score a woman is given more closely matches the actual observed outcomes. So this is a little bit of the science and the data that we've done most recently that we'll be presenting this year at our next big RSNA or Radiological Society of North America meeting in Chicago. And this is when I was talking earlier about patients with dense breast tissue versus our AI risk score. So we have very large databases from global centers. For this particular study, we had 6 US and 1 European site and almost 250,000 screening mammograms with 5-year follow-up. So if we look first at the not dense versus dense column and down at the bottom, if you had dense breast tissue, you were overall in a group of women where 3.2% developed breast cancer in the 5 years after the mammogram. If you were identified as having not dense breast tissue, so fatty or scattered, that number or percent of women that were diagnosed with breast cancer was 2.7%. Overall, for everyone, the cancer incidence was 2.9%. So if the average was 2.9 and you were dense, you were just a little bit higher than that. And with the average 2.9%, if you were not dense, you were just a little bit lower than that. But what we can see from this, if we look in the final column, this column shows exams in the first row here that had an AI risk score that was average, less than 1.7%. The middle group had intermediate risk between 1.7 and 3%, and these are the thresholds that the NCCN and other guidelines committees use. And then the high risk group was just under 6%. So this is a much better way, this column, of triaging women into average, intermediate, and high risk so we can more appropriately guide them to the most effective care pathway for their early detection and their cancer prevention. Another way I like to look at this table is to think about the women who had not dense breast tissue, so we wouldn't really be paying a lot of attention to them, but had a high AI risk score. This is a very high rate of cancer, 5.7%. And they do not have dense breast tissue. If they had dense breast tissue and a high AI risk score, then it was 6.2%. But we would be missing a lot of patients at high risk if we took the full complexity of data from the mammogram rather than just this crude dense, not dense assessment. I also really am focused and care a lot about these young women. We tend to lag a bit in changing guidelines based on the available research, especially in breast cancer screening. Honestly, it was only about a year or so ago that the USPSTF finally recommended women starting at 40 undergo screening mammography. Until that time, they really felt that you should wait until 50. And yet, we all could see how many more women in their 40s were being diagnosed with breast cancer. And because of the screening recommendations that were waiting until 50, we felt so many of these women in their 40s were being ignored and not having the advantages of early detection through screening. Honestly, I think we're starting to see these trends in women under 40. Now, why are we not screening everyone in their 30s? Well, for the same reason 5 years ago we weren't screening everyone in their 40s, because we try to look at that balance of how many women don't undergo breast cancer diagnosis and those that do, and who do we really want to screen. But what we see here is that it's the AI risk score rather than age that can help direct the most effective screening strategies. So if we look at women in the 50 to 69 age group, these white and black, dots, these are women that were average risk, and they had a very low rate of cancer, far less than 1.7% risk over the subsequent 5 years. And these intermediate risk patients, just as our model would predict, fell between 1.7 and 3%. And then the high risk were above 6%. So this is a way for us to really target those women that we really, really want to pay attention to. But we can see that we have women well above 3 and 4% across all the decades, whether it's younger than 40, 40 to 49, 50 to 70, or over 70. So I really want to make sure we're paying careful attention to these women at very high risk, and we can be somewhat more reassuring to those at average or even low risk. So this is a domain that I'm excited about. I can envision in the future. We actually go back to the old days in the 1970s where the American Cancer Society said you need a baseline at 35. I think we should have a baseline at 30, have a good, strong AI risk score, and then have a risk-based pathway. Maybe that 30-year-old needs to go ahead and start screening mammography in her 30s, just as we do for women in their 30s if they have a first-degree relative diagnosed with breast cancer before the age of 50. So we're already doing screening in the 30s. We're just not doing it in all the women that are at high risk in their 30s. So now from detection to prediction, how do we move into prevention? So just as a summary, cancer is common, it's deadly, it impacts longevity. Screening is age-based and it just misses too many women. And our traditional risk models miss too many women as well. So we have an image-based AI risk score. It's more accurate, it's more equitable, it's accessible, and we want to ensure that more women are receiving the right care at the right time, guided by a more personalized risk approach. But also, now that we have these AI image-based risk models, we can test them over time. And what we're finding is that they are not static, they are dynamic. What does that mean? It means that my score 2 years ago may not be the same 2 years from now, and I want to know if that changes. And because they're dynamic, we can support more effective and more personalized breast cancer prevention, because as we make an intervention, we can now test to see if that intervention had an impact. So this will be presented this winter also at our radiology meeting. And so the red line represents women who were diagnosed with breast cancer in a very large screening program. So this is the cancer diagnosis. We went back in time from that breast cancer diagnosis to the prior mammogram. That prior mammogram had a very high AI risk score. And then we went back another year and found it was still high, and even another year. And then we were looking at the slope of this line 4 and 5 years before the cancer was diagnosed. And we're seeing that the slope of a woman destined to develop breast cancer is steeper than women who do not develop breast cancer. And so it may be similar to how we track PSAs. It's not just the value of the PSA, but has it changed since the prior testing? So couldn't be more excited about this domain. We have AI risk assessment models to empower women for effective personalized screening, supporting access to imaging technology beyond the mammogram to the right patient at the right time, and importantly, to actually prevent cancer, partnering with drug companies that are developing better medications, trying to have more adjusted, personalized risk reduction medications. I think really we're opening up a new door to that because we have an intermediate risk marker to assess more quickly whether or not in that particular patient there's an impact. It reminds me a little bit of if you were trying to develop medication like statins and you couldn't measure cholesterol, so you just gave one group the statins, the other group the placebo, and waited to see who had a heart attack. It'd be a lot harder to decide what dose do you need of your statin. Is this the particular one that you seem to respond to, that your body seems to respond to? So I'm really excited about this domain. The last thing, where are we going to take this? Super excited about this. Cardiovascular disease in women, it's the leading cause of death. Women, unfortunately, are less likely to be screened for cardiovascular disease. They're more likely to have delayed treatment, and they're more likely to die from heart disease compared to their male counterparts. We're still trying to move out of this old school thinking that heart disease and the risk of heart attacks is really a male disease, that this isn't what women have. We even have these old expressions of the widowmaker, when clearly we need so much more research in cardiovascular disease in women. 40% of women skip their regular screenings, citing time constraints, cost concerns, and lack of awareness. So, how exciting would it be if we could link the awareness of breast cancer, as many women are regularly getting their screening mammograms, and extracting not only from that visit information about their future breast cancer, but also their future cardiovascular disease? And the reason why I think that's so possible and reasonable is, again, people have been sort of noticing since the 1970s and 80s. Gosh, have you noticed these things that we see in the breast? Like some of the vessels are calcifying, or some of the tissue just looks different. And maybe the breast tissue is keeping a record of so much that happens in the lifespan of the woman. So when she had her first period, how many periods did she have? Did she have children? Did she breastfeed? Was her weight fluctuating or not? Did she have diabetes? And so many people have been studying the very faint signal of breast density and showing that these very faint signals track with predicting many different diseases in a woman. And I think by the same application that we use to really amplify those signals with AI for breast cancer, we're going to do the same thing in heart health and brain health and many other diseases that impact women. So I'll just close by thanking incredible colleagues here in Boston. And increasingly, some of these folks are going into different places and taking this technology and this research with them. It's really been a pleasure both on the academic side and on the startup side. Again, that new domain for me. And I really hope we can have a good discussion and look forward to your questions.
Thank you so much, Dr. Lehman, for that amazing talk and introduction. Let me look at the question and answer section. Let's see here. Okay, the first question is, what are your thoughts on hormone therapy for menopausal women who have recovered from breast cancer?
Oh, that is such a good question. All right, so I'll tell you the answer that everyone is supposed to say is there's a whole body of evidence that has really come under very harsh criticism, I believe rightly, for the approach that was taken regarding removing women without a breast cancer diagnosis from hormone replacement. So I can talk about that. For those patients who've been diagnosed with breast cancer and then are really wanting to go back on hormone replacement, I think that's a little trickier. And I honestly feel that I don't have the research available to have a clear statement about that. So at this time, I still feel like the most prudent approach is if a patient has had a breast cancer diagnosis, to not go on exogenous hormone. However, I think it's a great conversation to have with one's medical oncologist, primary care doctor, gynecologist, whoever you're seeing. Now, on the other side, which I can talk about, are women who had not been diagnosed with breast cancer and the whole story of what exactly happened that overnight all women in the US were told stop taking hormones. And I think it's an unfortunate story. I don't know if folks have read the book called Blind Spot by Marty McCary, but he has a chapter on this, and he really just walks through the story of what was happening. And I was in Seattle at University of Washington, Fred Hutch at the time. And I remember when it was happening and thinking, many of us were talking like the study really wasn't powered for the claims that they're talking about. The patients that were in that study were older. It wasn't women that were just going through menopause or were perimenopausal. So there were a lot of flaws to it. And the claims, I believe we're all really more aware and recognizing were overblown. And it was unfortunate because many, many women benefit immensely in their peri and postmenopausal years from hormone replacement, many different kinds of hormone replacement. So one size doesn't fit all, but I do think we've clearly identified there are many safe pathways. The difference between, estrogen patches or estrogen creams versus oral. I mean, there's a lot of different considerations. So I always encourage women to talk to their doctors and ask them about the potential benefits and risks and have that informed discussion.
I agree with you 100%. A big proponent of hormone replacement therapy. I mean, people get a simple UTI and get infected. I mean, it's just it's done a disservice to women. So I agree with you. The next question is, can you tell us when you think the software will be adopted by insurance and mainstream medicine?
I will tell you, I am pushing so hard at every level. It's like, okay, you get FDA authorization. Now you can start talking to health systems and you can start talking to the payers. So I had the very good fortune of being at a innovation conference and I met uh, Secretary, I guess he's called Secretary Klomp, oversees Medicare. Um, he is so aligned with what we want to do. How do you have access to women living in rural communities? How do you reduce waste? How do you improve the impact of our tools, particularly in the domain of screening mammography? So we've submitted our proposals there. We have submitted our science and research to our guidelines committees to hopefully be included in the guidelines. So we're really moving as fast as we can in these different areas, as well as talking to different payers state by state. We're very eager to shorten what can sometimes be a very long gap between FDA authorization, the clinical research, and then approval for payment. And the payment is going to be needed to make sure that we have the access at an equitable level that we want. Usually, when there's that gap, there's going to be some element of an option for self-pay. With each health system we're talking with, we're exploring different possibilities of within their ecosystem what works best.
That's wonderful. And then what enhanced screenings are you recommending for high risk score patients? Are you? Mhm.
Yeah,
Yes.
so I think it's all about vascular enhanced imaging. That is how we find these cancers that elude us on the mammogram. I think the science is so clear, and I know sometimes people don't like to hear this, but the science is so clear. If you add vascular enhanced imaging, and there's two kinds that we have that I think are relevant, a breast MRI or something called a contrast enhanced mammogram. They both watch blood flow as it goes into the breast tissue, and they both have shown incredibly high sensitivity and added cancer detection and diagnosis compared to a regular mammogram. I know a lot of women love ultrasound, and I will tell you the science is so clear. The bump up in added cancer detection is tiny. It is dwarfed by contrast enhanced mammography. and contrast enhanced MRI. So I really encourage women, if they can, to get an MRI or a contrast enhanced mammogram if they are at increased risk. I think we're going to see more and more CEM. I'm a huge fan of it. Very strong studies showing equivalent performance compared to MRI. In fact, the largest randomized trial that's been concluded in England shows it's actually better. If you look at that research, it's clearly the test of choice. It should be much more accessible, much less expensive. And so I'm a big proponent of contrast enhanced mammography for our patients at increased risk.
Yes. Yeah, I had a dear friend recently diagnosed with breast cancer, and she said the mammogram missed it, and she had a contrast and MRI, and she had her mastectomy, and she's a cure now. She's doing well. But are you looking at risk scores in the context of hormone replacement therapy? Is another question.
Yes, a colleague of mine, Jack Cusack, was really interested in how density changes. And so he found that you could have interventions and the density would change. So if you put someone, for example, on tamoxifen, which is a chemoprevention medication to reduce a woman's breast cancer risk, the density would change. Again, that's that faint signal that we can now amplify with AI. And we also know that the density can change with when women go on hormones. And so we watch for that. My hunch is that now we have a risk tool that can assess changes with these interventions, changes in diet, changes in lifestyle, changes on hormones. We're going to start to pull out for the individual woman what that impact is on her body. So back to the other question, the one was like, well, what if after successful breast cancer treatment, would it be safe to go on hormones? I think we need more science and studies, but maybe there are certain women whose breast tissue just doesn't respond the same way to exogenous hormones as others do. And we were very careful with our FDA authorization to include women with a personal history of breast cancer because we wanted to make sure that this could work whether you have a personal breast cancer history or not, whether you have implants. We didn't want to have all those exclusions that a lot of other software programs have. So I'm really excited about for the future.
Well, one of our viewers said, this talk made me so excited for the future. I know you mentioned that Clarity is being rolled out to thousands of women, but can you talk further about the availability of this technology? For instance, could a patient pay for a risk assessment before?
The simple answer is yes. And so at our website, we're really trying to get things set up and moving as fast as we can. So there's two approaches as a company that we are taking. The overarching mission and vision is access. We even call the platform Clarity Access. How can we make sure that as many women as possible get access? Not just the women that happen to live on the Stanford campus or in a neighborhood next to Mass General Hospital, but everywhere. So going into health systems is one way to provide greater access, but we're also partnering with different groups that can say, well, the mammogram's already been taken. We're not a company that needs to have all the, bricks and mortars to take a bunch of mammograms. The mammogram's been taken. What if we could help that woman send us the mammogram, and then we could process it on our cloud and then provide the score back? Totally aligned with what the FDA has requested as far as, needing a request from a healthcare provider for that, and then being able to provide wrapped around the assistance of a healthcare provider, what the score means and what to do next and what that's like. So we've set up that more direct, wrapped around health system support, Clarity Access, and I'm really excited about that. There's a lot of moving pieces to it because, for example, every woman owns her mammogram, so she has every right, and by law, centers that have the mammogram have to supply it to her. It's a lot easier for these health systems to share the mammogram with another health system. So if I picked up the phone and called Mass General and said, I want my mammogram sent to Emory, they could easily push a button and send it. If I want it, it's a different process. They're going to mail me a CD. Now, centers all around the country have lots of different ways that they can share images. Some women have easier access, some it's back to the CD, some wait for weeks and weeks, some can go and pick it up that day. So we're working with all the complexities of our lovely US health system on how can we have more women be able to access this. But we're really excited about that and want to start expanding that as quickly as we can.
Fantastic. Another question, is this software applicable for 2D versus 3D mammography?
Fantastic question. So our first model that's been authorized was trained and tested and authorized on hologic mammograms, 2D acquired. So there's two types of mammograms. There's actually, sometimes I say there's three kinds of mammograms. One is 2D, and that's a snapshot of the breast. The other 3D or tomosynthesis is if you're getting your mammogram and the machine sort of either just stepwise make an arc or it makes a smooth pass, but it's moving. There's movement to it. And that is taking multiple images or slices of the breast tissue. Now, with those slices, you can put them together and make something called a 2D synthetic exam. So there are many centers, once we had 2D synthetic, that said, well, we're going to continue to acquire the 2D snapshot. Then we'll do that sweep and we'll present both to the radiologist. And about roughly half of the centers in the US still want that, what we refer to as a combination. It's 2D with the 3D sweep. There's about another half that said, we don't think we need to do the 2D anymore. And there's pros and cons on both sides. Some people feel they can see calcifications better with the combo method. Others feel, well, why have extra radiation if we feel you don't really need the 2D? So that's an evolving area. But we do know we want the model to work on all vendors and all types of mammograms. So we've been evaluating and testing, and we're preparing to submit to the FDA for our 3D or a 2D synthetic. So it works with whether it's a 3D or a 2D image, it would work, as well as a multi-vendor application. So working on that as fast as we can and think that's really important for 2026.
Fantastic. One of our attendees, is mammogram the most effective method to diagnose breast cancer? How about ultrasound or CT scan? Because mammograms can be quite painful. So
I know, right? Well, so here's the thing. Every grant I've ever reviewed, it always starts off by talking about how terrible mammography is. But the problem is, and the reason why it's still around, is it's really hard to beat it. It just is. Um, I really want women to hear that a mammogram should never be painful. Really let the technologist know. When you schedule, say, I always find my mammogram very painful. I'm really looking for a different way to approach having a mammogram. And maybe talk to your friends. Go to a center maybe that's particularly sensitive to how to take a very high quality, excellent mammogram without it being painful. Sometimes the pain is because the skin is being stretched or caught. I mean, there's ways to engage with a technologist and talk about having. Now, it's not something like, I mean, actually, I would much rather have a mammogram than get my teeth cleaned. There's something about getting my teeth cleaned I absolutely hate. I dread it. I hate it. But I do it every 6 months and I get my mammogram and then it's over. But it shouldn't be painful, and it is the best we have. And ultrasound, while I know people love it because you don't have to have your breast compressed, but it misses so many cancers as a screening device. So it's fantastic. I use it all the time for a diagnostic tool, but it's just a very, very poor second for a screening exam.
and then on ultrasound, do you have any thoughts on the new 3D ultrasound techniques that are becoming available?
Yeah, we've done quite a bit of research actually on the automated breast ultrasound. So it is when you have the exam, you're lying on your back. There's rather than a little handheld transducer that a technologist or a radiologist is moving around your breast, it's a pretty big plate that they put down, and this huge transducer moves across, taking a full capture of the breast tissue, and it's 3D. It's a really good technology. We've compared it head to head with handheld, and it really, really performs well. And it has some advantages because you can store the full exam, and it's not just dependent on where someone's hand happened to stop or look or take a snapshot. You're getting the whole movie and the whole movie captured. It also provides fantastic data to develop AI tools to do a better job of reviewing all that data in the breast on the ultrasound. So it may be in the future a 3D AI assisted ultrasound is as good as a mammogram. We're excited about these kinds of opportunities to explore, and we'll see what the future holds.
Another question, what do you think of liquid biopsy for breast cancer detection, such as GRAIL?
Right. So we would so much love it if we had a blood test. If whenever you went in to see your doctor, you could have your blood panel looking at your hemoglobin A1C, looking at your cholesterol levels, looking at your breast cancer risk profile. Unfortunately, they're just not ready for prime time to find women out in populations that have breast cancer. We are hopeful, and we think maybe for subsets of women, they might be really helpful. Maybe they'll be synergistic. Maybe those types of liquid biopsies, along with other kinds of tests, might be the right match. Maybe if you found certain women that are at very high risk for certain types of breast cancers, those types of blood tests added to their other screening and testing would be helpful. But at this point, just my feeling from the data is not ready for prime time, and certainly I don't know of anyone that would recommend it as a replacement to screening mammography.
I agree. For someone who wants to take a proactive approach to prevention, how should we think about using mammograms, MRIs, genetic testing for early screening?
So I think the first thing when you're thinking about prevention is all the things that I'm sure the human longevity community thinks about. What are the things that will keep us as healthy with as high quality of life as long as possible? How can we have that, strong, empowered, graceful aging? How do we stay active? Think about the diet that we have, the lifestyle that we have. I think all those are so important for the full spectrum of disease and health states, including breast cancer. So, all of that I think is really important. And then I think to know your risk. So be as healthy as you can and then know your risk. And now we have better ways of knowing your risk, but I realize we're very early in getting it out there and accessible to everyone. So at this point, if you have a family history, make sure you've let your doctor know about that. While there are problems with the traditional risk models, there is not a problem with a patient who's identified a strong family history saying, I know I'm an increased risk just based on my family history alone. Or if you have a family member that's been tested positive for a genetic mutation, really think about the pros and cons of being tested. Because if you are at increased risk, we want you to follow a different pathway for early detection and for prevention of cancer. So I think we are looking at different recommendations for the best way to screen for early detection based on your risk. Um, Mammography, if you're at average risk, if you're at increased risk, adding either MRI or contrast enhanced mammography to that. And for prevention, if you're at average risk, the lifestyle changes that keeps everyone healthy. If you're really at significantly increased risk, you want to talk to your doctor about pros and cons of chemo prevention. Some of these medications available to reduce a woman's very high risk. And even for women that are, for example, patients that have been identified with BRCA genetic mutations, which confers a very high risk of future breast cancer, some of those women are going to consider prophylactic mastectomy. And that's a very personal and individual choice, but something to think about. There are also certain genetic mutations for breast that track with other cancers as well, particularly ovarian cancer. So those are conversations and discussions that women have. And that sort of, in some ways, it feels like a very crude way to avoid the cancer, to remove the ovaries or to move the breast. But in these times where many women are making those decisions, particularly after they've had their children, if they have children, there are also methods that women are using before they have their children to have different options going forward. But I think these are all in the spectrum of the considerations that we make.
Yes. We have so many questions, but we have about 10 minutes or 9 minutes. I'm going to just go through a few more. Are there specific warning signs or subtle changes that patients often overlook but should pay more attention to between screenings?
Yes, thank you. Whoever asked that, thank you so much. I have all these stories that I hate. One story, one group of patients I just really hate is when they're like, oh, they're 36-year-old that come in with an advanced cancer and they're like, I didn't know it mattered that there are family members on my father's side. No one ever told me. I just didn't know that. And everyone on the father's side, all the women have had breast cancer and some of the men. So that is painful. It's also painful when a woman comes in with a fairly aggressive cancer and says, but my mammogram was negative, so I kept ignoring the lump. I thought it can't be anything because my mammogram was negative. I got a clear bill of health. We try to really highlight on every report, like, if you notice something, a change in your breast, it doesn't matter that you had a negative mammogram. We want you to call that attention to that with your doctor. And there's a different form of imaging that we're going to do, particularly with ultrasound, if there's a focal area that seems different despite a negative mammogram. So what would that be? You might feel a thickening. You might feel an actual lump. It could be a pea-sized lump. It could just be tiny, but it's something that just doesn't feel right to you. It could also be a sense of weird tugging or pulling, or you see that there seems like this funny wrinkling that you didn't used to have on your skin. And also, there's sort of a myth out there that, oh, if it hurts, it's not cancer, it's a cyst. And that's just not true. So you can have a cancer developing and there will be pain associated with it. So I wouldn't be paying attention to if it hurts or not. If it's a change in your breast, bring it to the attention of your doctor. And in most cases, if it's a change and you're concerned about it, we're going to want to do diagnostic imaging with ultrasound and mammography.
300%. Beyond screening, what lifestyle or metabolic factors have the biggest impact on reducing breast cancer risk?
Well, that's a great question. There's some cancers that it's really straightforward, like lung cancer, smoking, skin cancer, sun. I mean, there's some GI cancers that are really focused on certain diets. Breast cancer is honestly, it's a little trickier. The strongest risk factors we've had is being a woman and getting older. Like those two things. It's just like that's why it impacts so many women. It's just because it is, it's not something that's really specific to a certain subgroup of women. And then, of course, the risk factors of the family history. As far as the lifestyle, you know, everyone would have said 3, 4, 5, 6 years ago, oh, it's women that take exogenous hormones or hormone replacement therapy, and that's just been refuted. That's just not true. So I don't know. What do you think? I don't think there's anyone that leads.
Yeah, yeah, it's hard. I think being a woman, I mean, the number one reason for cancer is aging, right? And being a woman, having breasts, but,
Yeah.
taking your vitamin D, maybe eating an anti-inflammatory diet, exercising, optimizing your hormones rather than overdoing them. Those are just tips that I tell patients. So, it says, how do hormonal changes, menopause, HRT, or pregnancy history influence how often I should screen? There's another question.
So
Yeah.
at this time,
Yes.
we are still saying that we really want to see all women everywhere, no matter how many children you had, if you breastfed, whether you're pre or postmenopausal. We want all women to start screening no later than 40 with mammography. And what was the question then? I sort of missed.
Yeah, just saying that, they're talking about menopause, HRT, and pregnancy history, if they've been pregnant or not, influence how often I should screen. I don't know if those really change
Right. So I
screening
wouldn't, so
guidelines, but yes.
yeah, those are sort of
Mhm.
in the domain of
Yes.
differential exposures to hormones and your reproductive health and all
Yeah.
of that. And I would say that we are not using those to
Yeah.
screen differentially at this time.
No, we're not. And then what's your view on this, on supplements or anti-inflammatory diets and supporting breast health?
Well, so this is where I'm going to be looking at you. I love it as a radiologist. I feel like I'm being asked more as a woman than a
I know.
radiologist because I'm
Yeah.
just like,
Yes.
where's what I think. But I don't know. I basically think there's this overall health pattern, and it can be really hard to follow all the things like, which supplement 5 years ago was popular, which one is now. But at least what for my own health, what I pay attention to is making sure that my levels of vitamin D are okay. I mean, I take biotin because if I don't, my hair and my nails are sort of weak, but I don't even know if that's scientific or not. And then that's pretty, I really focus a
Yeah.
lot on trying to eat a really healthy plant-based diet. I am an omnivore, so I'm not completely vegetarian, although boy, when Jane Goodall told us all to be vegetarian, it was really hard to hear that. So I've been thinking about that more, but largely plant-based, I think.
Yes, yes. And the last and final question, it's about alcohol. So can you comment on breast cancer and alcohol intake?
So, the alcohol story has also changed a lot, and it seems like the current law, and I'd love to hear what you tell your patients or what you think, is that if you don't drink, don't start. And if you do drink, then drink in moderation. And that is, I don't know if it makes sense that it's totally gender rather than body size or, how you metabolize alcohol or whatever, but it seems like in moderation is, a glass a night kind of thing. I don't know, depending on all kinds of other factors. But what do you tell your patients?
I mean, there is a link between alcohol, I think, and various cancers or breast cancer. We know it's a neurotoxin. So in the longevity space, we try to encourage our patients to moderate or not drink as much or get rid of it if they're APOE4, they're prone to Alzheimer's. But it's a pastime in the US and it depends what age group you're in. But I think now they said there's a reduction in the younger generation with drinking alcohol, my
Well, that'd
generation.
be
Right.
interesting, right? To see
Yes.
how that tracks. Yeah.
Yes, yeah, so, but anyway, this was like a fascinating, fascinating talk. We're so honored to have you present and this tool. I'm just so excited for women and that they're going to be able to use this to predict and prevent breast cancer. This is revolutionary, So thank you
Thank
so
you so much. Thank you so
thank
much for
thank
having me.
you
It's
so
been a
much.
pleasure and have a great evening.
So grateful. Take care of yourself. Okay, bye-bye.